Welcome to our video history. Today we're fortunate to have as our person to interview Dr. Norman Gant, who is currently the Executive Vice President of the American Board of Obstetrics and Gynecology. Norman, thank you for being with us today.
Good to be here.
We're happy to have you here. Let's begin with a little bit of your background. Tell me where you were born.
A place called Wichita Falls, Texas. Not Wichita, Wichita Falls.
That's not Fort Spunky that you referred to.
No, I joke about being from Fort Spunky Star Route, but that's where I was born. It's in north central Texas, about 12 miles below the Red River.
Now, have you lived in Texas all your life?
My entire life except the year I took over the board.
Now, tell me a little bit about your background. Where did you go to high school?
Went to high school in Wichita Falls, senior high school. In those days, there was only one high school, Ralph. I was very fortunate. I grew up poor, but the school was well heeled because of oil money, oil and around there, the tax base. We had a great high school.
Then you elected to go on to college. Where was that?
North Texas State in Denton. Simple reason. $39 a semester, not an hour, $39 a semester.
Were you there in a dormitory or was it a commuter college?
Well, no, Denton was 100 or so miles away from Wichita Falls, just north of Dallas. I lived in the dorm the first year, fraternity house one semester, and then Smith's Floyd Hamlet Funeral Home, where I got room and laundry if I'd take ambulance and death call every other night. And that's where.
Tell me about taking death call. What was that supposed to be?
You were on call every other night. Somebody called in and said, Mrs. Smith has died at the hospital. You got up and went with the undertaker to retrieve the body. Or if there was a car wreck on one of the highways, on either way, you went out and retrieved the victims and took them to the hospital. It's a way I could stay in school.
When did you decide to go to medical school?
I think I decided when I was 6 years old. Very ill at one time with osteomyelitis in my clavicle. And I kind of liked the doctors, even though they were doing kind of weird things to me. But my role model was my aunt, who went to medical school. She's a graduate at the University of Pittsburgh, and she was a pediatrician, and she was my role model.
Which medical school did you go to?
UT Southwestern. Again, I'll always be eternally grateful. It was $300 a year.
That was
it. And that's what it remained, and actually until 1985. So I could afford to go to medical school. That's the best $1,200 I ever invested in my life.
And when did you decide you wanted to be an obstetrician?
Rather late. I had decided I'd be an internist. And one day, Ralph, I decided as I was walking down the hall, I could tell my patients by the sounds they were making. It was kind of like a Martin Denny record. You may not remember Martin Denny, but in the background of his songs were jungle cries. And I could walk down the hall and hear, leave me alone, ooh, ooh, ow, ow. And I suddenly realized that this is awfully depressing. So I liked surgery, I liked the challenge of internal medicine, and I could do both in OB-GYN.
Where did you take that residency?
UT Southwestern Parkland Hospital, Dallas. My chief was Jack Pritchard, and I think I was the last one he hired. And I will always be grateful for him letting me into the residency program.
Tell me a little bit about your experience in residency. We all know of Parkland and Parkland's reputation, the large volume you see. You even had President Kennedy there.
I was a senior medical student that year. I actually was at Methodist that year and helped helped, that's a light word. I was standing there with the resident who took the bullet out of Officer Tippett. And no, that was kind of an interesting day. But Parkland, it's an excess of everything that you could want. Every illness in the world, every medical illness, surgical illness, from malaria to leishmaniasis, you get to see it. And it was just plain fun. Somebody said, Gant, you're acting like a blind dog in a meat house. That's a West Texas story for you. But everywhere you looked, there was something, and it was just marvelous training. And of course, Dr. Pritchard and Peggy Wally and Paul MacDonald and Reuben Adams were the faculty, and these were wonderful teachers and wonderful clinicians and wonderful researchers.
It sounds almost like a who's who in our specialty.
As I said, I was a very lucky man, very lucky man.
You finished your residency, and at that time, we still had internships, I assume. Where did you intern?
At Parkland. I was an intern at Parkland, and as I said, it was a late decision to do OB-GYN rather than internal medicine. And I finished the residency in '68.
And then what did you do?
Much to my surprise, Dr. Pritchard offered me a chance to be a fellow in his lab in hematology, and I thought, well, I'll rest. That was a mistake. I haven't rested since, but I really had a marvelous time. I spent a year with Dr. Pritchard, Jack Pritchard, in hematology. Then I spent the next 2 years in reproductive endocrinology and fertility with Paul MacDonald and Finn Cedric in the lab. And
did you have any clinical responsibilities during this time?
oh yes, we staffed service every 3 months. Well, the first 6 months I was strictly in the lab. After that, we staffed service every 3 months. Now, when we staffed service, that meant that at that time you were in charge of 3 OB services and 3 GYN services.
And all the residents related?
And all the residents related, and that was an in-house population of about 230 patients. So it was one person each month staffing the service. Again, it was fun, but it kind of kept you off the streets at night.
Once you finished your fellowship, what were your plans?
I wanted to stay in the lab and do research and do patient care, but I had been so turned on to the research, and I was given a chance to stay in the lab 2 out of 3 months. So it was an ideal situation for me.
Did you officially join the faculty?
Oh yes, I actually as a fellow, in those days the board didn't have the approved fellowships. I was appointed as an assistant professor when I started with Jack Pritchard right out of my residency.
How many research papers did you do during that time?
Well, I don't know. It was kind of funny. I thought I was going to do endocrinology, and my chair then, Dr. MacDonald, said, no, you're going to do maternal fetal medicine. And I said, why? And he said, because you've got NIH funding in obstetrics. So I became a maternal fetal medicine specialist instead of an endocrinologist because I was doing work in hypertension in pregnancy. So that's kind of how that came about.
You're recognized in our specialty as one of the leaders in hypertension and hypertension research. Why did you move toward hypertension? Or was that something that Dr. Pritchard said you will do?
No, it just evolved. I was studying clearances of steroids, at the rate and fate of steroid production in pregnancy, and I noticed that the metabolic clearance rate of the precursor to estrogen, dehydroepiandrosterone sulfate, was increased in normal pregnant women, and I did this clearance rate in this one woman who was just normotensive and happy as she could be, and 5 weeks later, she was very sick with preeclampsia, and I had detected a fall in the clearance rate, which was an indirect measurement of uteroplacental blood flow. And wow, you mean blood flow has decreased the baby when she's still normotensive. I wonder what else is happening. And I was aware of the work that Leon Chesley and Fred Zuspan had done with angiotensin infused, and Peggy Wally, by the way. So I said, I wonder, normal pregnant women were refractory to pressor agents, but if you were preeclamptic or hypertensive, you were very sensitive. So I took one of these women that I'd seen the metabolic clearance rate fall in, infused her with angiotensin, and she got preeclampsia. How could you not get interested? You know, you've seen two things that are happening long before women get sick. And it wasn't lightning like eclampsia. It was something that had been going on for weeks before they got sick. And that's how it happened. It was just kind of stumbling along.
And that started your career.
Well, it bought me a lot of beans and cornbread as after dinner speakers. Anyway, it helped, but it was fun.
And how long did you stay at Parkland?
Been there forever. Still am. Even the year when I took over the board and lived in Seattle, as my wife pointed out to me, I came home twice a month, and I said, to see you, she said, you came home to take night call. No, I'm still on the faculty at UT Southwestern.
Why did you decide to take over the role of director of the board?
That's a very complex issue. I was not elected to do this. The person who was elected was Clarence Ehrlich, another Texan and an oncologist and a good friend. And Clarence was going to do it and literally dropped dead at his desk at Indianapolis 2 months before the executive director at that time, Jim Merrill, was going to step down. And it kind of, there wasn't anybody else kind of at that late time to do it. So I was a director, and somebody said, no, I know why you did it. It was to undo all the votes you'd lost earlier. But that's how it came about. It was an accident.
Now, as I recall, when Jim, in his last years as the director, was in Seattle, and so you moved to Seattle.
Again, he had already made plans to leave on January the 1st, and this was the end of October. So I went to the boards in Chicago in December, and from there to Seattle.
And once you took over, the board began to look at finding a permanent home. What was the rationale behind that? Because they'd never really had a permanent home.
Well, I've got to confess, since they needed somebody and I was the one available, I applied a little pressure. I agreed to take the job if we'd have a permanent home, and a permanent home would be Dallas. And my rationale for Dallas is, obviously I love Dallas, but even more importantly, we had DFW, the Dallas-Fort Worth Airport. And you could have a meeting with somebody from the West Coast, the East Coast, getting there, starting a meeting at 1 o'clock, and people be home at night. Not only that, but in the winter, we didn't have ice and snow, and it didn't take an hour and a half to get from O'Hare to downtown Chicago.
Did you consider Chicago?
Yes, I certainly did. And one of the reasons is because of Al Gerby, one of our, just one of the nicest people you'd ever know. Al so loved Chicago and had been a director for many years and an employee of the board. But the final reason was geography. Mid-country, far enough south, not a bad winter, easy access, and I knew the real estate market fairly well.
Now, you built the building.
Well, I bought a building and then added to it.
I remember hearing that you were in a bid with Roger Staubach.
He was interested in the building. He was interested in the building. he is a commercial realtor there. And when my real estate agent said this was a Resolution Trust building, an RTC building, which I bought for a good price. And they're going to ask you how you're going to pay for it. And I said, just tell them that I'm going to pay for it with cash and small denominational bills. And the realtor said, why? I said, I want that guy to know I'm a serious person who's going to buy this. If he thinks I have airplanes that fly under the radar, good for him. I really did that.
Now, once you have purchased the building, you've made some very major changes in the way the board examination is given.
Oh, yeah.
What was the basis of those?
For all those years that we'd been doing oral exams, as you very well know as an oral examiner, it was in a hotel room. It was just not professionally done. It was time to take this out of a hotel bedroom and put it into a professional building. It was time to have computers with all the computer power that you can use to generate graphics and to conduct something in a professional manner. And that's the best way I can describe it.
Tell us a little bit about how the exam is given today so that our viewers 20 years from now or 40 years from now will understand, because we do remember the original part where you did sit in a hotel room with a candidate and go over their list.
Well, that was another real reason. I had not immediately agreed to be a director when it was offered to me because of my concern about the oral exam and how unstandardized it was. At the time, you and I came through, and the whole concept was to make this as level a playing field as you possibly could, so that instead of one person just making up a case and talking to you, so two other people in another room just asking anything they wanted to from your case list. The case list varied so much from person to person that to have a fair exam, it just seemed reasonable that there would be standard questions with standard disease states and pathophysiology and the questions asked. So half of our exam are structured cases now. We have an hour in OB, an hour in Gyn, and an hour in office practice. 30 minutes is still the case list, so we can see how somebody practices. But the other 30 minutes are standard cases, and every candidate that day gets the same question, and all the questions that are asked. All the examiners each day know what is an acceptable answer. And you know as well as I do, in clinical medicine, there's more than one possibility. So they're all briefed, they all know what the various possibilities are, and I can't make it any fairer than that right now. Future? I think that with nanotechnology, as we were talking about a minute ago, we'll have virtual reality, we'll have real simulation. Now, we have that to a certain degree with our computers, but it's still not what you'd want. It's still kind of cartoonish.
One of the things that is most people who take their exams find is a tremendous amount of stress. What are some of the things you've done to reduce this stressful?
Boy, it is stressful. First of all, they're not held in a bullpen like you and I were. When we went through, you know, you went and the cigarette smoke was down to here, the toilets were. What we do is we bring them into a hotel that's separate from where the examiners are, so they don't run into an examiner in the hall and, you know, panic. They're in their own hotel. In the morning, we serve them breakfast. In the afternoon, lunch. I come in, talk to them a little bit, try to talk them down. They've been told what the process is in writing. We then take them to the test center where the director of evaluation explains once again exactly how the exam will be given. Most importantly, we get the results of that exam out on Monday following the Friday afternoon exam. We don't have to make them sit around and wait for 6 weeks like we did. We have the ability to do that now.
And Norman, as I understand it, you're a member of the Institute of Medicine.
Yeah, I am.
And you were selected on the basis of what?
Lord knows if I know. I think because of the research, and I think some of the research has proven to be valid over the years, and I'm certain the board had something to do with it, but primarily research.
There are very few OBGYNs in the Institute of Medicine. That's quite an honor that you're there.
Well, Mother would probably be very proud. I would hope so.
Moving along just one further step, understand that you're a fly fisherman.
Oh boy, yes. Oh yes.
How did you develop that?
My father-in-law taught me to fly fish. He was a family doctor. And I think he planned his fly fishing for 51 weeks out of the year, and he taught me to fly fish. I'd never done anything like that. And I was not a young person at the time I learned, but I love it.
Tell me, at the board, what has been your most memorable experience in the time that you've been the director there?
It's not a single experience. It's I think it's a combination of the sort of evolutionary process that's led to the way the exams are conducted now in the test center. And I think that my partner in doing this was not just the directors, but it had to be Bill Drogemuller. Bill just, we saw eye to eye in the alteration of the test process. So I think I'd call it a process. And the directors who all got behind the building of the test center and adding that to the national headquarters. That is a process. It's not a single thing. And it was done by every director, but especially with Drogemuller, and now with Larry Gilstrap, who succeeded him and has worked so tightly with the college. I don't have to tell you this, but I don't think our maintenance of certification and what we're doing to keep people current, our doctors current, could have happened without the cooperation between the college and the board. So it's a process. It's the changing of the exam. It's the way the exam is given, and the acceptance of our profession, reluctantly, I admit, but the acceptance of our profession that this is good for women.
If on the opposite side, what would you say has been your most disappointing experience? Besides dealing with the ABMS.
I wasn't going to bring that one up, but I'm going to have to bring it up. I think at the moment my most disappointing experience has been with the ABMS. Not because of bad people or process. It's just we have 24 different boards all seeing the elephant in a different way. We're like the blind man describing an elephant. And it's been a very, very disruptive sort of thing. I think our maintenance of certification process that's been done between the board and the college is the best of any one of any of the 24 boards in the more than 100 subspecialties. I know it is as a fact. And yet, some of the larger boards, if we don't do it their way, they think we're doing it wrong, and we're not. We now have at least 3 other boards about to copy what we do. with our annual board certification process, and they're even talking about the modules we've developed between the college and the board. So I think ultimately we'll win.
If you could make one change in our specialty, what change would that be?
I think I'd try to put the joy back into being a doctor. I go around hearing gloom and doom and oh me, poor me. We're the luckiest people that ever lived. I'm here at the annual clinical meeting, and I'm walking down the aisles of all the technical things that we have, the minimally invasive surgery, all of these marvelous things. I hear the bad things about big pharma. Well, my Lord, the things that big pharma have given us, I know they're expensive, but when you and I were interns, when we treated heart failure, we had digitalis and 2 cc's of mercuryhydrin. We didn't even have thiazide diuretics. We've got alpha and beta blockers. We have angiotensin converting enzyme inhibitors. We don't die of heart disease now. We put in stents. We do cabbages, but you put in a stent, you've got to have, I'm not doing this as a commercial, Plavix. All these marvelous drugs that we'd never heard of. We have lived in the greatest time to ever be a doctor. And I think we need to kind of put that joy back into our training for our house staff. You know, oh me, I'm working, I do this. Hell, they're down to 80 hours a week, which they should be. They ought to be less than that probably. They've got the greatest tools in the history of mankind to be a physician. Oh man, I just want to put the joy back.
What do you see the future of our specialty?
Women will always be pregnant. They'll always need us. Ralph, in 1930, 800 women per 100,000 died in childbirth. Today, they don't die in childbirth unless they get hit by a car on the way to the hospital, or they have end-stage renal disease. The deaths that occur now are virtually unpredictable. We have turned obstetrics from a medical surgical thing into a social happening. Let's burn feathers and invite the neighbors in, you know? It's amazing. We have prevention of cancer, liver cancer with hepatitis B immunization. We have immunizations against cervical cancer, against HPV. My Lord, RH disease gone away. It's a remarkable time to have seen these changes. So I think that to answer your question, I'm getting back to the happiness of being an obstetrician gynecologist. I couldn't ask for anything better.
You mentioned 1930. That was the foundation of the American board. I think you were the third board to be formed?
We were three. Ophthalmology, I think 1918, ENT 1926 or 27. We were incorporated in 1930.
A lot of people say that what you just referred to as the reduction in death in women was a direct responsibility of the forming of the American board. What do you think?
Oh, a major portion of it was because maternal mortality between 1930 and 1940 was halved by virtue of our board insisting that the delivery stop being done on a kitchen table and that women be provided care in a hospital with nursing care, proper nursing, anesthesia, and properly trained people. We didn't have penicillin until 1946 for the civilian population, so we didn't have antibiotics. The RH factor was just barely known, and that decrease in maternal mortality took place by providing well-trained, not only doctors, but nurses and anesthesia support. And it's before blood banking was safe and before we had antibiotics. So We've got a lot to be proud of with our profession.
I think most people in our specialty today would give the board the kudos for being what has changed our specialty.
Well,
It's made it what it is today.
Well, I agree, but I'm going to have to I'm going to have to throw a commercial in for the college because I'm a fellow of the college as well. The beauty of this relationship is, and it's a symbiotic relationship. The standards are set. We enforce the standards, but the continuing education is what the college has done for years to set up the standards that have kept people current and to provide the new technology and the setting to see some of these miraculous sort of devices. I am once again amazed every time I go through these industrial exhibits to see all the bells and whistles that are available that make surgery safer, less costly, and more convenient. It's just amazing.
Norman, I can't thank you enough for coming and being part of this. You have done much for our specialty, and we do appreciate it. Thank you on behalf of the college, and thank you on behalf of the specialty for all you've done.
Thank you, Ralph.